I guess the first decision that I assume you had to make, and maybe you can just walk us through the different big decisions that had to be made, is it safe to open schools? And how did you guys go about figuring that out and deciding how you would even decide if it was safe?
Yeah. Our retiring superintendent came out pretty strongly at the beginning saying, if there's any way that we can get back to school in person, that would be our goal. And so the task force was kind of went in with that mindset saying, okay, what things need to be done in order for us to be in person? And my role more than anything else was to kind of take all of the data that's been coming out from, it's an onslaught of literature that's come out since March, try to synthesize that into a rational understanding of what the risks and the benefits are for kids going back to school and being in person. So that decision going back to school being made then meant that it was, what are the actual risks? And is this something that's feasible if we take appropriate steps? As an ICU doctor, I tend to think of things as risks and benefits always. How do risks happen? Are there any things we can do to mitigate those? And this was definitely a situation where the risk was always going to be there. It was just how did we manage that? And so it started like most things do in medicine. When you have a question, you start going through the papers and spending a lot of time sifting through things, trying to decide which pieces of data work, which pieces make sense, which pieces have enough weight that you can kind of hang your hat on them.
Right.
And so that's kind of where we started.
And in kids, it's often the case, regardless of COVID, but all of medicine, that there's just not as much data as in adults. And so that makes it additionally challenging because you can't just apply what we see with kids or with adults down to kids and expect it to be the exact same, I imagine.
Exactly. There was also a lag time, with publications and stuff. And so it was really lucky from an ICU standpoint that we had, that the team at Boston Children's had organized an international Zoom call, initially twice a week and then weekly, to kind of update the critical care community about what was being seen. We were able to hear status updates from Houston and New York City and Boston at that time, and really kind of dive into what should we be doing as pediatric critical care providers. And that was really helpful because there was a lot of boots on the ground information that if we had waited till the publications ran through, then we would have been a little bit further behind. The good news is also, though, that starting about middle of May, there started to become a groundswell of editorials in some of the major journals talking about how we needed to come back to school, and that because of the role that schools have in our society as kind of a stopgap measure for a lot of things that kids need, that there were real harms that came about by keeping kids out of school, whether that was food insecurity, PT, speech, occupational therapy, just normal socialization of our kids. Those things were coming out too. And that kind of led to an increase in the number of publications that were coming out looking specifically at kids.
Because I think you could say, well, there would be fewer cases if we just didn't go to school. And that would keep everybody from getting coronavirus or keep a larger segment from getting coronavirus. But we know, like you were saying, that in medicine, we have to balance the risks and benefits. And we have to balance the individual risks and benefits with the societal risks and benefits. And we know that being in school is important for a lot of kids, as you spoke to, in checking in on them, making sure they get food, making sure that they're safe and secure, because it's easy to think, well, we can just keep our kids home. Well, that's not an option for a lot of families in our country, where they rely on school for food. They rely on school so that the parent can work to put food on the table and keep them sheltered and everything like that. And then all the therapy that goes on and just the socialization and learning that happens in the school environment, that those are things that must be included in the calculation of, is this safe?
Yeah. So go ahead.
I was just going to say, and it sounds like that's what you're going to say too, is so after you decided, okay, we're going to work in every way possible to reopen schools, then it comes to like, how do we feasibly do that? And what can we do to mitigate the risk or limit it to as much as possible? So what did that look like, or how did that work out?
Yeah, so we kind of were able to very early on. I was able to kind of show that the risks to kids are low, whether it's contracting the condition, whether that's being hospitalized from it, or whether that's being severely ill and needing ICU level therapies. There's a international, or not a national, there's a North American PICU database that's tracking COVID admissions, COVID deaths, at least ones that happen in the ICU. And last I checked just now, there's still less than 1,000 pediatric ICU admissions for positive coronavirus cases.
Wow.
It's not the end all be all of the counting, but for a database that's pretty well maintained, it's pretty impressive that there's been that few ICU admissions.
Despite over like 1 million or 3 million cases in the US now, there are less than 1,000 children in the ICU, which, I mean, it sounds like a lot when you just say there's 1,000 kids that have been admitted to the ICU for COVID. But when we look at 3 million cases in a country of 250, 300 million people, that's still very small where they're getting admitted to the ICU.
Yeah. So that was kind of the first part of, okay, so what are the kids' risks of having this? And again, recognizing the limitations that we'd been, on lockdown and kids hadn't been exposed to their normal cohorts and that sort of thing. So that was the first thing. And that made people feel, more confident that, okay, this is something where the risk to kids is low. Around that same time was also when I started to find some things about the biological plausibility about why kids don't get as sick with the illness, which I thought was important too. It made it to me seem more like, okay, it's not just that they're not being exposed, it's that there's actual real differences between kids and adults that explains their overall risk assessment. And so some of the stuff about the ACE2 receptor and the levels that are expressed throughout lung tissue and that sort of thing in kids really made me feel more confident that, okay, not only is it just not exposure, it's biological. So then we started looking at some of the transmission data, and there were a number of studies that came out of Europe and Australia that really kind of did some really good contact tracing within schools. And I thought that was important to say, okay, it's not just in the community, but when you looked at schools, you could actually say, okay, kids are less likely to transmit it to their peers and to their teachers, because that's the other half of the school picture is what do you do with the adults? And I think if it had been something where we could say, oh yeah, kids are fine, but they are definitely going to spread it to adults rapidly, I think that would change that risk assessment.
For sure.
Say, what are the benefits? Because if you don't have teachers, then you don't have school.
Right.
Or
if they're going home and infecting their relatives, parents, grandparents, those sort of things, and leading to more spread in the community, what's going to be the burden on the healthcare system if all of a sudden all these kids go back to school and then all these adults that are in contact with kids start coming down with COVID. So looking at the transmission from kid to kid and kid to adult, I'm sure was something that had to be figured out too.
Yeah. And then the last kind of portion of it was, okay, it's low risk for kids, it's low risk for transmission. How do we make that risk even smaller if we can? And that's when it came down to social distancing. And again, it came down to balancing the risks and benefits of masking and distancing and that sort of thing to really determine, is this something that's still feasible? Putting these measures in place. One of the things that we ran into early on was that in diagramming what the size of the classrooms were across the archdiocese, there were a lot of older school buildings, and if the recommendation was going to be that we had to be 6 feet apart, there was going to be a lot of schools that wouldn't be able to meet that.
Sure.
And so we looked at it on the Lancet meta-analysis of transmission on distance and masking and goggles that came out end of May, early June. Was really important for me to look back at and see, okay, what's the overall risk reduction with social distancing? And with that, we were able to feel like six feet is ideal. But there's a lot of places throughout the world that are really only going at 3 feet or a meter social distancing, and seeing that reduction kind of tailed off as you got further away, not unexpectedly, but there is a diminishing returns for each foot that you're further apart. So we felt confident saying that with masks, with at least 3 feet, but ideally as much as you can get, that there would be something that was reasonable for most of our schools.
So that sounds like, you kind of had to like look at those things and say, if we're doing masks, the risk is reduced. If we're doing at least 3 feet and possibly more when able, that the risk is reduced to a level that we feel comfortable that the benefit of school outweighs the risk of spreading coronavirus, of more cases. And how did that play in when we're looking at all of the different, like it'd be one thing if kids stayed in one room the whole time throughout the day and didn't migrate around the school. How were those decisions made? Lunch, recess, specials, all the different components of a day where you're out of the classroom.
Yeah. So what we ended up deciding was kind of a tiered masking recommendation set of guidelines. So for the younger kids, given their lower risk than the teenagers, we felt that the kids under second grade, actually we were going to do under 10 based off of the data, could be mask free. But in talking with our principals, they said, you know what, we frequently group our pre-K through second graders together for various activities, assemblies, that sort of stuff. We keep third, fourth, and fifth grade together typically, and then the sixth, seventh, and eighth graders are kind of their own group. So let's try to keep it in kind of our standard delineations and divisions that way. And so we actually said pre-K through second could go mask-free most of the time when they were less likely to keep social distancing. So hallways, drop-off, pickup, that sort of thing, we recommended masking. The third, fourth, and fifth graders, we said when they're in the common areas, they need to wear masks. That's going to be a requirement. And we strongly recommend that when they're in their classrooms, but again, hopefully 4, 5, 6 feet apart, they can be mask-free. And then the sixth, seventh, and eighth graders were going to be wear masks all the time.
Okay.
So that was kind of where we ended up on our recommendations. The high schools were a lot harder. The high schools are one of those things where, because of the structure of high school in the U.S., we kind of just said they have to wear their masks all the time and try to distance them as much as possible. But it's going to be harder for contact tracing because you can't. There's mixing of classes. You have sophomores in 12th grade math. You have remediation and that sort of thing. And so we left that up to the principals to kind of try to figure out how they were going to manage that themselves.
Right. In high school, like you move from room to room a lot more. You don't have like a home room. You just move from room to room. Hallways are crowded. I mean, overcrowding is huge, especially in our high schools locally. And I know around the country, it's the same issue with overcrowding. And then they're the ones that are the most social and probably need the socialization the most for their age. And so getting them to buy into wearing masks and also physical distancing is going to be even more challenging than the young ones, where you can just kind of talk them through and help them and realize they're not going to be perfect. I think that what you've laid out is very similar to what I've seen from different pediatricians around the country, little variations based on individual issues in communities. But I've seen that kind of tiered approach where the youngest kids, it would be great if you could wear masks as much as possible, understanding that they can't, that they need to be able to see the teacher's mouth in a special way so that they can keep learning language and everything along those lines. And then as they get older, increasing the expectation of wearing masks, knowing that the older kids are more likely to transmit coronavirus than the younger ones as well.
Yeah. And then for the rest of the specials, we really felt like being outside made a huge difference. And so as much as we could be outside, that was a time when kids would be able to go mask free. So whether that's PE, recess, even just teaching outside, if there's space available, we felt that those were recommendations that we felt comfortable with. And I think that that's the other thing for all kids is that it's, yes, you need to wear your mask, but you can take your mask off for brief periods of time. It's a risk mitigation strategy. It's not, it would be one thing if this would completely eliminate all risk and you say, okay, let's be 100% of the time or as close to it, let's wear masks. But when we're taking your risk from, and these are ballpark numbers that don't mean anything, but if it's a 10% risk without masks and it's a 3% risk with masks, then can we get you to 5%? And those
Right.
are worthwhile risk reductions that matter. But it also, obviates the fact that it's not something that is ever going to go away.
I think that's the thing that I try and explain to parents too, is often it's like, well, they're not going to wear it perfectly. And it's okay if they don't wear it perfectly. Just like when we give measles vaccine, 97, 98% of people respond to that and mount an immune system, but there's 2 in every 100 that are susceptible to measles, and we don't know who those people are, but we rely on the high vaccination rate of everyone else to protect them, even though they're not immune. And in the same way, if we're all doing our best to social distance and mask, it's okay if not everybody is perfect all the time. And it's not, no matter what we do, unless we just do virtual learning for the foreseeable future, are we going to take the risk down to zero? And we know that the risk doesn't have to be zero to feel comfortable being in a school setting, because kids are less likely to get severe illness, because kids are less likely to transmit. So we can just work our best to reduce the risk, and then be comfortable with realizing that, like, I hate wearing my mask all the time too. It is uncomfortable, and I have to take breaks and pull it off and take some, breaths just to feel comfortable. And these masks are so itchy after a while. Like, I understand that nobody's going to be perfect, and you don't have to be perfect. And if you try and get your kid to be perfect about it, it's probably going to cause so much anxiety and stress that they're not going to want to wear it at all. They're just going to refuse to do it.
Yeah, exactly. Totally.
So you've got a plan. What's it going to look like for going forward once we open the doors to class, kids start coming in, and the community transmission changes? How did you guys start to broach that idea of, like, what do we do on September 15th when there's a positive in a classroom or a positive in a school? What's that going to look like?
So the wild card in all of this is we're still not sure what the departments of public health are going to do. Fun fact about the state of Georgia, it has more counties than any other state in the union, with the exception of Texas. And so the Atlanta metro area has something like 11 different counties that are a part of it. The Office of Catholic Schools has schools in, I think, 5 different counties.
Oh, wow.
Within one archdiocese. So there's an element that we don't know, that we can't predict in terms of what the departments of public health are going to say we need to do if
Sure.
there's a positive case. Our hope is that it's only going to be classroom by classroom.
Sure.
That would put kids into quarantine, and maybe even smaller than that. But we don't know quite yet. We have taken steps that if we need to pivot to virtual learning, the schools are getting the equipment that they need to do that. The high schools had already had virtual days in place as just kind of a standard portion of their curriculum. So they were able to easily do that, and the kids know what to expect. It's been harder for the elementary schools to kind of get to that point, though.
Sure.
And understandably so. And again, I think it comes down to, if we can do as much as we can to be in person and mitigate that risk, then hopefully the number of virtual days is limited as well. I think the other thing that was really hard for us to figure out was, what do we do with a kid who has strep throat and fever, and shows up and gets sick during the school day, and how do we treat that? And so we kind of decided that we were going to operate under the impression that that you do not have coronavirus until proven otherwise.
Okay.
So you are not guilty until somebody else says it's there. And then we also felt that there was a real need not to burden our system of healthcare in the city. So we are not requiring doctor's notes, and we are not requiring negative PCR tests because we can't necessarily trust all of those things.
Sure.
A lot of the urgent cares here, they see kids, but how thorough of a job are they doing? How well do they know pediatrics? That's always a question. Our infectious disease team here at Children's Healthcare of Atlanta has real concerns about screening nasopharyngeal swabs for asymptomatic patients, noting that the FDA approvals, the EUAs, were all for symptomatic patients.
Right.
And knowing that there's probably going to be a whole lot more false negatives for asymptomatic patients. So we didn't feel like we could hang our hat on that. We didn't feel like it was going to reduce our risk by any measurable means. And it was going to be something that was hard for our pediatricians, our urgent cares, and the families as well to have to get to the doctor's office. You know, there's some school districts that are talking about, 2 negative tests
Right.
before coming back and that. And so it ends up being something that we felt like if you're symptom free for 48 hours, not using fever reducing medications, those sorts of things, that it's probably okay to come back. And again, it comes down to risk versus benefits and
Right.
and what we felt comfortable with.
Well, and the availability of tests and vials and all the different components that have to be available to test. Because testing a whole school district at I've heard people talk about that. It's like, that's 42,000 tests in Lincoln, Nebraska that you'd have to do, which would be way more than is done on a daily or weekly basis for just a point in time when people are probably not likely to have it before the school year starts here. And so expecting that every time that a kid has a runny nose or a cough or sneezes or anything like that, that they're going to be able to get a PCR test, let alone 2 tests before they can come back to school, is burdensome on the healthcare system, the parents, the kid, the teacher, to constantly be vigilant of who just sneezed and who just coughed, and we got to isolate them. Again, recognizing that things aren't going to be perfect, but we're going to do what we can. I think that's probably been the hardest thing for parents that I've talked with, is just the uncertainty and realizing that you can do everything right and you can get exposed, and you can do nothing right and not get exposed. And that it just makes it really hard at the end of the day to know what you're doing matters, that you're not doing too little and you're not doing too much.
Yeah, I think that's been one of the biggest learning experiences for me through all of this is how poorly even many doctors don't understand statistics and things like pretest probability and how your prevalence in your community really changes things. I see things on social media all the time about, cases are skyrocketing in Texas in the childcare centers. And it's like, well, those are stories, not studies.
Sure.
And when you actually go through and look at how many outbreaks have actually happened, there's no reporting on any of that. So just because there's a bunch of kids in daycares that have it doesn't mean that it's coming from the daycares.
Right.
And so I think that those sorts of things really matter, and how you approach it and understand what the actual risks are. And it's, risk is hard to quantify in a lot of ways, but knowing that, okay, in Lincoln, Nebraska, there's far fewer cases in Lincoln than there are in Atlanta right now.
Right.
So the risk in Lincoln in general should be lower
Right.
than it is here. That doesn't mean that you ignore it and you don't take steps to reduce your risk or that you're any safer. It just means that my risk is lower.
Right. And things change. It's so fluid that it could be totally different in 2 weeks from now. 3 weeks from now, Texas bars and everything like that were reopened. And so it just is constantly in flux, and a good reminder that all things are local. And so understanding what's going on locally is most important, rather than what you're seeing or hearing reported from around the country. Are there any other learning points or messages for parents as everybody prepares to go back to school that you think would help give some peace in the midst of all this uncertainty and worry?
I think what, like we talked about, that we're not striving for perfection, that we're striving for just really good. I think that one of the things that I've seen on your social media posts is talking about how we ask kids to do hard things all the time, and kids are really resilient and able to do that. Certainly in the ICU setting, it's not easy for kids to keep their high flow nasal cannula on, but we still work through it. And usually by the end of their hospital stays, most kids aren't yanking it off.
Sure.
And so masks can be the same way. And I think it's always important to just recognize that just like we ask kids to keep their hands to themselves, masks keep their germs to themselves. And that's something else that I think is getting lost. People keep thinking, oh, well, this mask isn't going to protect me. And it's like, well, no, it's not protecting yourself. It's protecting those around you. And so just trying to keep your germs to yourself is there. And then as far as school opening, it really is important that everybody be flexible, and work with what you can, and try to do the social distancing measures to the greatest extent, and recognizing that things are going to change, and maybe in 6 months from now all of this will be gone. Maybe in 6 months from now this is all going to be worse, and we just don't know yet. But that doesn't mean that we can't try. That doesn't mean that we can't move forward and try to get back, and capture the benefits that schools provide to our kids.
Well, I think that is really an important message to remind people of too, is that like we're all in this together, and if we can all just do our own part and help and be willing to understand that like nobody has the perfect playbook. If everybody had the perfect playbook, we would just hit copy paste and we wouldn't have to have all these meetings. Everyone's having all these meetings because no one is sure what's right, but we have to pick something and move forward, realizing that it's not going to be perfect. And we don't have to blame when things don't go quite as expected, or we don't have to shame a parent because their kid had coronavirus, because any of our kids could have had it, just like anybody can get lice. And just to give grace in this moment, and realize that it won't be perfect, and that's okay. And like you said, kids can do hard things, adults can do hard things. I mean, look back at what we did in World War II with victory gardens and not driving and all the different things that our society sacrificed for the sake of people around the world. And we can do these things that are a little uncomfortable or seem to impose on us too much, that it's not that much of an imposition when we look at the grand scheme of things. And it helps. It's kindness, and it's being generous and thoughtful to your fellow humans.
Yeah.
Awesome. Well, thank you so much. Thank you for being on the front lines. Thank you for taking the time to work through all of these meetings that you all had to come up with these guidelines, because it's really helpful to see what other people are doing so that not everybody has to reinvent the playbook completely. And I will make sure, I would love to have you back on in the fall and see how things are going and see what we've learned in that time. The nice thing that, like you said, is we've learned so much in such a short period of time. There's still so much we don't know, but we've learned a lot, and it's been a good refresher on virology and biostatistics for me. I will make a plug for, there's a great podcast, if you're a podcast listener, called This Week in Virology. All they do is cover coronavirus, not just the clinical stuff, but the lab stuff and the public health stuff. And it's really like a well done show. I listen to it. That's the only podcast that I listen to the very day it comes out, because it's so up to date. And so I would recommend that if you're looking for something to watch or listen to.
Sure.
All right. Well, thanks so much, Dr. Geoff Mickells. Keep up the good work. Stay safe, and good luck with your little family that's growing.
Yes. Thank you.
Well, I hope that was educational and instructional for you to kind of hear what it's like on the front lines from a fellow pediatrician. And we're all working through all of these issues as community members, trying to figure out what we can do to keep everybody safe, to get kids back to school, to help take care of families. It's a challenge. I mean, I think we are equipped to handle it. And as Dr. Mickells and I talked about, it's a matter of everybody doing the best they can, realizing that things aren't going to be perfect, and moving forward with a plan, knowing that it won't be perfect and that we will have to adjust. But that is something that we are well equipped to do, and we have the safety and security and infrastructure to pivot and to move as we need to, just like we did back in March. So I hope this has been helpful. If you would you share this with somebody? Just click the little share button below, and you can share it straight away to your newsfeed or tag somebody in it, so that we can get that more information out to more and more families. Because I think if we all realize how hard everyone is working, there'll be more grace, and we will get back into the swing of school more easily. And I wanted to say, I'm doing a summit for parents. It's called the Back to School Summit. And if you go to backtoschool.co, you will find the information to register and come to the summit. There's going to be a dozen parenting experts talking about not just coronavirus. I promise it's not going to be all about mass and physical distancing. It's going to talk more so about the mindset of returning to the school year. I had planned this and had things in the works long before coronavirus. And so it's going to be an epic 3-night virtual summit. Tina Payne-Bryson, Debbie Reber, Craig Campanari. There's a whole list. I can't think of everyone off the top of my head. Abigail Gwertz, myself, several others. Allison Escalante. Sorry. I'm trying to think of everyone and give everyone credit, but I just have been talking with people in the last couple of days too about being a part of it. It's at backtoschool.co, and I would love for you to join. I would love for you to be there and get to hear from these experts how to prepare for the school year, how to prepare mind-wise to engage and connect with your child, how to be present for your family, and to focus more on family connection, to focus more on the child and engaging with them rather than getting distracted by all the activities and the stress and the meetings and everything else, just to focus on your family, focus on connecting and supporting your child, making it a great school year for them and for you as well. So it's backtoschool.co to join, and I hope I get to see you there.